It's my pleasure to bring Dr. Ryan Westergaard to our educational session. And since Mary is the chair of this committee, I'll have you do the introduction, Mary.
Oh, thank you, Linda. So I guess to introduce Dr. Westergaard, I would say that if there is a public health issue, if there is a health equity issue, then Dr. Westergaard is the man that you want at the table. His work has always been committed to community and to the public, and he engages community regardless of where you are. So my experience with Dr. Westergaard meeting was through the Department of Corrections and his work that he's done with research and helping and assisting our population with access to healthcare and understanding their health needs and promoting that in the community. So he's a real big champion for the health of the community, and I've enjoyed working with him, and he is the state medical director. So Dr. Ryan Westergaard.
Great. Well, thank you, Mary. I thank you for inviting me here, and thank you for the nice introduction. And if I didn't oversell my Zoom skills, I'm gonna get my presentation loaded. And it's nice to be with you all. I'm actually kind of glad it's a small group, because my goal was really to get to know you as an organization and allow you to get to know me, because as Mary said, I have a lot of interest in global health and public health from a human rights perspective, and care very deeply about social justice. And that's really why I am in public health rather than just working in a clinic somewhere as I went through my medical training. And Mary suggested that I talk about COVID from a global perspective, and certainly have talked a lot about COVID every day for the past 2 years, and have given a lot of presentations. And I thought that the way that I talk about COVID was just to kind of tell a couple of stories about my involvement in the COVID response in Wisconsin. And I frame it this way. You see, my title doesn't have anything to do with COVID necessarily, but it's about academic health departments and universities. And the reason that I developed this talk was I was asked to reflect several times, both in media availabilities and in Q&A of talks that I've given, about what do I think was the best thing that I learned, or the best thing, or any silver lining that happens through the pandemic response. And on balance, of course, it's been an enormous tragedy and with a lot of suffering. But when I try to look at silver linings and think about the things that I think have really made us stronger, the thing that was first and foremost in my mind was that, in my experience here at a state health department, the energy that we got from engaging with people who are learning and studying and practicing in public health, and breaking down those divisions between people who are in training, who consider themselves scholars and academics, and the people who are doing applied work. And that was very affirming to me, because when I took this position a couple of years ago, I was very much in the academic medical world. I'm an associate professor at the medical school here in Madison. I've studied public health, and I've been engaged in advocating for public health, but I've never worked for a public health department. And so what I hoped to bring to this role here at the Department of Health Services was that lens, or those ability to build bridges and use the scientific resources that we have in the university to do public health better, and also to help our learners learn what public health is and recruit people to work in public health. So that I wanted to talk about our COVID-19 journey in Wisconsin public health through that lens. And so I talk a lot about the strengths of the university, and I started with these presentations. It's felt more and more important to do a land acknowledgement. I mean, where I'm here now, I'm at 1 West Wilson. I'm right by the Capitol in our campus. for all of the actually wonderful legacies and strengths that we also have this legacy of actually working and living on stolen land. And so when I talk about this rich legacy of the university, I also want to acknowledge the ethnic cleansing that occurred in the area where we now live, and acknowledge that that was a past wrong, and elevate the fact that our university, from the chancellor on chancellor's level throughout leadership, want to acknowledge that and honor that legacy so we can learn from it. And this is that other somewhat unique legacy that the University of Wisconsin has that really resonates with me and is a principle that I think guides my work. And you've probably heard this if you're from Dane County, but the Wisconsin idea that the education should influence people's lives beyond the boundaries of the classroom. So the true extension of the campus is actually the boundaries of this state, and the work that we do in the university is to benefit the people. And that's a concept that's very meaningful to me as someone who works in the School of Medicine. And now that I have the opportunity to work for the government in a different capacity, it's a perspective that I try to bring. So when Mary asked me to talk, I wanted to talk about the COVID-19 pandemic through that lens. But in the past week, I was reflecting more on working in public health and all the things that seem to have changed overnight with the war in Europe. And it took me back, as I was mentioning, to some of the studying that I did, some of the mentorship that I got when I was in my training. And I wanted to talk through that sort of just as my personal history. And you already talked about Eleanor Roosevelt, and my journey through medicine and public health really led me to a place where I was very interested in learning about these international frameworks, global frameworks for human rights. When I was an undergraduate here at the University of Wisconsin, I took this little known opportunity to make your own major, and I majored in bioethics. So I had a mentor in the philosophy department, and I just picked all the classes that looked most interesting to me. And so I ended up taking a lot of health policy and anthropology and some of the classes about medical ethics and how we do research in a way that respects autonomy and justice, and how that intersects with healthcare. And so when after I graduated from the University of Wisconsin, I went to medical school in Baltimore at Johns Hopkins and had the opportunity to study for, I think, a total of 4 years at the Bloomberg School of Public Health. And that school, both through the Master's in Public Health program and also the PhD program that I did, has essentially a certificate program in health and human rights. And I had the opportunity to take this seminar series that was led by Bob Lawrence, who I think is on a picture on my next slide here, who was an internal medicine physician who was one of the founders for the International Physicians for the Prevention of Nuclear War, which won the Nobel Peace Prize in 1985. And the US chapter of PSR, or of that organization, now has rebranded itself as Physicians for Social Responsibility. And Bob Lawrence was a professor at the School of Public Health. He's done everything from human rights investigations in developing countries and war-torn regions to studying environmental justice and starting a center. He started the Center for a Livable Future. And he's one of the people that really has influenced me. And we went through this, this seminar series that was longitudinal, and learned about the International Conventions for Civil and Political Rights and the areas in which that intersects with health policy. And it really resonated with me because, as a physician who was interested in public health, we get trained to look more upstream. We're initially trained to study people with illness, but then you look at what are the social factors and the political factors and the environmental factors that influence the trajectory of people's lives so they become sick. And if you want to prevent illness, looking at the social conditions that determine health. And when you get a master's degree in public health, you really study a lot of those things. You study structural racism and generational poverty and food and housing insecurity. And you really look at what determines what makes people healthy in a more holistic way. And it was while I was at, Johns Hopkins School of Public Health in 2003, a poignant thing happened when I was learning about this holistic view of what makes people healthy, is that there's an alternate force that comes by every once in a while that in almost every conceivable way is the opposite and opposed to all of the forces that create health. And that, of course, is war. And thinking of that as the ultimate moral sin and the antithesis of the conditions that make health really framed how I looked at the world back then. And this all came back to me this week when we're seeing this again. We had a sense of complacency that we had moved on to a healthier place and learned lessons. And just within the course of a week, we're back in this area where people are going to be dying of preventable illness because infrastructure has been demolished and there's no access to basic needs, food and safe water and medical care, and it's all preventable. And so physicians like Bob Lawrence really inspired me to see that it's not just physicians, but regardless of what our profession, as citizens, as global citizens, we can have a voice. And PSR in particular, and they've now started, making formal statements and petition with 10,000 people back, trying to make the case that there is no treatment for the health effects of nuclear war. There can only be prevention. And saying that through a public health narrative, through a medical narrative, and coming from trusted voices is very useful. So I thought I would just share that background on the occasion of getting invited to meet you all at the United Nations, and just to say that as we go forward in this new world, consider me your neighbor and colleague here in Dane County, and if there are activities around this at the intersection of health and human rights and how we respond to some of these global threats, I'd be happy to be involved. Okay, I'm going to talk about COVID next, but I wanted to frame one last thing about my past work, which will be relevant kind of toward the end. And this was, while I was at Hopkins studying health and human rights, among other things, my formal training or my research training focused on the intersection of infectious diseases like HIV and viral hepatitis and substance use disorder. And Baltimore was an opportune place to learn about how those systems work and how to study those really, really challenging behavioral health and social problems. And I did my training with a research group called the ALIVE study, which followed people who had a history of predominantly heroin addiction and injected drugs, and lived in the prominently the east side of Baltimore City, which was a very impoverished area. And it was really an opportunity, as I was learning research skills, to see a public health problem of HIV and increasingly opioid overdose through this holistic lens of social determinants of health, like I was talking about before. And the project that I did was looking at, in this group of men and women who were living with HIV, what are the things that determine whether they're doing well with HIV or they're getting sick with HIV? And this was in the early 2000s, where this was in the you remember the beginning, the first couple decades of the AIDS epidemic. Everyone got very sick and most people died. In 1996, we started having triple therapy where it became curable. And then that, like many health breakthroughs, started a division. It started a process of disparities where certain people accessed this new miracle treatment and did very well, and others did not access that well and continued to do poorly. So in this first decade of the HIV epidemic where we had treatment, we saw overall survival going up, but we saw widening disparities in who was getting sick with HIV and AIDS and who was on track to live a long and healthy life. And that sense of justice as fairness, of trying to see, well, what there are differences, there are disparities in health outcomes. What are the things that underlie these, and in what way are they structures that could be changed? That was the theme of the work that I wanted to do with this population. And so I designed a study looking at data that had been collected from this group of people with heroin addiction for over 20 years. And we looked at their data and we put them in two groups: the people for whom the treatment was effective and the virus stayed undetectable, and the other group for whom the virus was out of control, meaning they weren't taking their medications. And then the result of this project was to see, well, what are the top 5 things that are associated with uncontrolled HIV infection, or essentially not using the medication that is available. And the results were these. These were the top 5 things. Number 1 was whether the person was incarcerated in the past 6 months. And it was number 1 by far. Of all the things that we looked, and we used statistical methods to adjust to see, well, what are the main causes, what are the confounders? Being incarcerated was the number 1 predictor of whether someone's HIV was not under control. Second was whether they used cocaine, and then unemployment and homelessness. So clearly social determinants of health. So this was became kind of launched me on this now career 10 years later, where we realized that if we want to promote health equity, if we want to reduce these disparities between people who are healthy and people who are sick, for conditions that we have effective treatment, we need to get out of the hospital and out of clinics. We need to get into communities. We need to look upstream at policies, and criminal justice policy, particularly drug policy, is a key area that we need to look at for things like HIV and increasingly addiction. So with that in mind, I moved to Wisconsin and started my faculty position at the University of Wisconsin School of Medicine and Public Health. This is where I'm from. My whole extended family is here, and started doing this kind of research here in Wisconsin. And then, as I mentioned, about 2 years ago, had the opportunity to move into this position at the State Health Department. And this was really still my interest. My role here looks at communicable diseases in a broad sense. All reportable diseases are the work of our bureau, but I still have particular interest in this intersection with of addiction or substance use disorders and infectious diseases like HIV. And then this happened. Then the pandemic started, and I think 110% of my effort was taken up by the pandemic response. And I'm just now starting to get back to some of these other activities. And as Mary knows, we're working together on a project that's trying to improve the transition of people who are in prison, who get linked to medical care when they get into the community. And we're doing some of those things. But it's been, like many things, has been disrupted in a lot of ways by the COVID pandemic. So with that background of kind of what my interests and experience has been, I'll shift gears and talk about some of the lessons that we learned through the COVID response here in Wisconsin. And I want to talk about it through the way that Mary actually just described, really one of partnerships and community engagements. And the theme that'll go through all this is really that theme of many different sectors, from people working in industry and in government and in research fields and in healthcare fields, really were able to come together and work as partners in often unexpectedly productive ways. And as I said, that's been one of the things that's been very satisfying. So in addition to just being a transition slide, this slide that I'm showing here is our 2-year history of the pandemic in one snapshot. This is the epidemic curve. The red line is the rolling 7-day average of cases. And I think the simple way to look at this is, it started early 2020. It got bad in that first fall. It got better in the summer, and then it got bad again most recently. When I look at this, every little bump tells a story to me, because we followed these every single day of these 2 years. We've looked at this curve, wondering whether it's going to go up or down. And so I can identify these little bumps that are Thanksgiving of 2020 and Christmas and New Year's, and then the arrival of the Delta variant, and then the arrival of the Omicron variant. And there's a rich history that's going to be told from this epidemic, in years to come. And certainly we've learned a lot of things about how to respond to these kinds of infectious diseases, and, as I'll say, how to work together. So these are the three stories that I'll tell, the 3 experiences. One was a investigation of one of the very first outbreaks that we responded to in a youth camp. The second one was responding to the early days of outbreaks on college campuses. And there's some interesting communication science and political science lessons to be learned from that these days in retrospect seem very obvious, but we learned a lot of things in real time back then about how we communicate about things like face coverings and wearing masks and gathering in groups and going to work when you're sick, for example. And then the last topic I'll talk about is the health issues and COVID prevention in prisons and jails. So this first story starts in Walworth County, Wisconsin, which happens to be where I grew up. And it was the early summer, or actually I guess midsummer, July and August of 2020. And schools, as you probably recall, had been let out early for the summer. Schools were canceled in most areas of the country. They moved to Zoom with varying levels of success, and that whole spring semester into the early summer was highly disruptive. So this was the stay-at-home era, and we got a call from the health officers in Walworth County saying that they had gotten reports of positive test cases, positive COVID tests, and that the job of public health departments back then was to try to investigate every positive case and do contact tracing and find out where they are. Are they being isolated? Are people being quarantined? And they were calling for help because the people weren't returning their calls, and they knew that these positive tests were coming from a camp, and they were concerned there was a lot of transmission. And what had happened is a school from out of state had decided to try to do the rest of their school year in person. It was a small religious school, and they rented out a retreat center or a summer camp, and had the idea that if they all traveled there together, they quarantined beforehand, they all got tested before they got there, and they didn't interact with anyone outside of their community, they could essentially do their school in a bubble and do it safely. And there was a great deal of planning that went into this. They had physicians and medical researchers who were part of the faith community that had the school, so they were well advised, and they thought that they had it figured out. And all the students and staff were asked to quarantine for 2 weeks before they went to the school. They all had to show either a positive antibody test, which was evidence that they had already gotten COVID-19 and then therefore likely had some protection, and then or a negative PCR test a week before they got there. And overall, there were 152 students, and from all over the country. And once they got there, their plan was to not do social distancing, not wear masks, because they assumed that they could live in this bubble. And what happened, unfortunately, was that one of the students was tested negative the week before, but must have been in the incubation period because they got symptomatic the day after they got to camp. And this shows the results of our investigation. The very first student, the day after arrival to camp, developed symptoms, not severe symptoms, but severe enough that they went to urgent care and got tested, which was positive. The test came back the next day. Another student had already developed symptoms, and within a week, they had already had 15 to 20 cases, and it just started moving through very, very quickly. And the way that we got involved with this was, there was a lot of things that we didn't know back then, and including that, like, we're pretty comfortable now that children are unlikely to get severe disease, but we weren't counting on that back then. And so there was a lot of concern that, are we doing everything we can to prevent the spread? And then eventually the school was going to have to, the students were have to go back home. And so we needed to figure out how to get people isolated and to travel safely. And there was a lot of opportunities to meet with people at the, from the family, from the researchers. One of the medical supervisors was actually a professor at Johns Hopkins, and we knew a lot of the same people. We were able to get on the phone and really talk through what they were doing, and had a Zoom call with, this is back when Zoom wasn't as normal as it is now, with about 60 parents. And we decided that what we would do is try to do a mass testing activity. So we got supplies from the State Lab of Hygiene. We got some students. We had a preventive medicine resident who was a physician here, and a trainee in public health, and we worked together to go and interview every single person, to test everybody all at once over the course of the day, so we could isolate those that were positive and quarantine those aren't, with the goal of getting people, essentially everybody, in the clear by the time they needed to go. And we hadn't ever done anything like this, but the fact that we had these multiple people working together, that we had resources donated by the lab, the laboratory was able to, we drove them from the camp in Walworth County to the state lab. We were able to determine the last date that everyone was infectious. We were able to make sure that people didn't mix after that, and we were able to get everybody home at the time. And we were able to publish a nice paper showing that the strategy of just testing and hoping for the best isn't enough. This was before we really understood that masks were really effective, and this was used as a teaching point or a talking point by CDC when it became clearer that there were, and around the same time there were other summer camp outbreaks that were being reported with a very, very different story. And I think maybe I've shown, I showed this next slide. In this one student was positive, and then eventually 76% of students in this community, just through the normal meeting and at school, became positive. And it was a tremendous effort to get everybody tested and come back. And then at the same time, and I've used this case study many times, particularly in school groups, because this same scenario played out at a series of camps in Maine around the same time, but they did things very differently, and the outcomes were very different. So they had the same thing where everyone quarantined before camp, tested before camp, but then in addition to just doing those things, they also quarantined people in small groups. They wore masks. They did daily symptom screening. They cohortings, meaning that you kept your pod of 5 to 10 students, and if anyone got sick, you all quarantined. And they did what we now call layered interventions. And even though there was 1,000 campers and staff, they had one positive camper and actually had no additional infections. So lesson learned there. The second case study I wanted to talk about happened in Winnebago County, Wisconsin. And this also started from a somewhat anxiety-laden phone call from a health officer. And this one went that they were seeing just spikes of cases in their jurisdiction that were getting reported in the specific age group of the 18 to 23-year-olds. So this was the whole, this graphic here shows the overall trend for all the age groups in Winnebago County, and they all kind of rose at the same time. They sort of stayed parallel to each other, and then starting in mid to late May, this happened, and it was a huge spike, and it was all people in this demographic. And this was not what I would call a medical mystery, what was going on. Like, it was pretty clear what was happening here. The stay-at-home order had been in force for about 2 months or so. And then those of you who are in Wisconsin may have recalled it was challenged in the Supreme Court, and the Supreme Court said that no, it can't, it has to end, because I don't really want to talk about it, but they said it was not legal that we had a stay-at-home order or public health orders. So what happened within days after that in Winnebago County, as many areas, is that the bars opened. And in Oshkosh in particular, there was a lot of college students who, that was also the time where they were moving and coming back in for summer session, because their campus had been called. So their things were getting going. And so bars were open, college students were mixing around, they were going to bars, they were not wearing masks, and there was a very rapid explosion of cases here. And the very concerning thing was that there were a lot of the students that were testing positive also worked in schools and worked in daycares and assisted living and worked in healthcare. So everyone was very nervous about what are we, there's these kids aren't getting very sick, but they're potentially exposing a lot of people, and no one seems to be doing anything about it. So that was the "come help us please" call. And like I mentioned, there wasn't as much to really investigate here, because we could see pretty clearly what was happening. The real challenge that I thought was, how do we communicate to large groups of people, and how do we understand how they're making their decisions so we can give people better advice? And I'll give away the end of the story here, is that we never really figured this out. As you all know, there's always been there's a lack of unanimity about the value and importance of masks. Varies very much by where you live, what communities you are, and it's been frankly frustrating for a lot of us in public health to spend a lot of time trying to understand and devise communication strategies, and feel like people really aren't listening. But we had to try. And what was really interesting about this response is that we, when the CDC asked us, are there, because this Winnebago County got on sort of the national spotlight because it was in the country, it was the hot spot. So we were talking with the federal response at CDC, and they said, well, what can we do to help? And whereas in some of the other outbreaks, they would send contact tracers and epidemiologists and cases, I said, I think we're actually okay with that. If we were going to get additional resources, can we try to get a handle on what are people thinking and doing, and what are the things that are going to make their decisions? And so they thought that was a good idea. And then what we ended up doing was essentially a social science investigation with a lot of interviews of people, and both who were students and people who were business owners, and tried to describe sort of what is the prevailing attitude. And they also collected quantitative data about who's getting sick and what they did and what were they doing. And this is a large table, but I just showed some of the things that I mentioned. Many, the two most common occupations, whether they worked in a restaurant or bar or they worked in healthcare, the young people. And then 58% of the people who were symptomatic had actually gone to work within the last 2 days, which is very concerning. And 82% had worked in the previous two weeks. So there was both social interaction, but also occupational exposures during this time. And it was also notable that 84% of the people tested positive were symptomatic. And in the younger group, that probably meant there were a lot of people who were not detected as well. So this scenario, of course, got replayed over and over in community after community, and it doesn't seem very novel now. But back then, we really had a challenge to try to understand how are we going to approach this. And so through some of these interviews, we learned some interesting things. Number one, when we asked young adults, it was very clear that people didn't at that time have strong feelings against masks, but they were essentially had the adolescent mindset. I don't want to be the only one. So you don't want to be that person. If no one else is going to wear a mask, I'm not going to wear a mask. I don't want to be seen as different. And that was the most common, response was like, there's nothing wrong with masks, but I'm not going to stick out by doing it. And then when we talked to business owners, the story was more economic one. A lot of them said that a lot of them were actually in favor of mask mandates because they thought that was the only way that people were going to wear masks. One business owner said, I can't mandate masks in my establishment, or everyone's just going to go to the bar across the street that doesn't. So that was a non-starter. So there was actually among business owners some support for the idea that we should just make a rule about masks back then. And of course that evolved in many complicated ways over the months and years that followed, but that was what we learned at the beginning. And this really stuck with me. And I think some of the things that we learned about and why this has become so polarizing is when you look at classical behavior change theories, and I've studied this in the HIV world in terms of how do you talk to people about wearing condoms when they have sex, or taking PrEP to prevent HIV, or sticking with your HIV treatment. So a lot of things in healthcare, especially infectious diseases that you need to take a medicine to prevent it, like HIV, really come down to individuals' choices. And we start with the assumption that everyone would rather be healthy than sick. But when you step back and say, well, why are people making decisions that are more likely to make them sick than healthy? It gets complicated. And so a lot of behavioral scientists have studied these health-related behaviors. And this is one of several prominent theories called the theory of reasoned action. And it was kind of of course, these are the types of things that determine whether people intend to do a behavior and do a behavior. It's what is everyone else doing? It's the social norms, and it's what are their attitudes about it? Self-efficacy means the sort of, this is probably not as relevant here. It's just like, if you decided to do it, you'd be able to do it. You feel capable of doing it. You have the confidence that you'd be able to do it. But really, it was this one that stuck out. And for me, what I talked this to, I shared this story and these data with policymakers and here of us, and in state government level. I said, this is why masks need to be the rule. It's not because we want to take people's liberty away. It's like, if we want to save lives, this is what determines whether people wear masks. This feels like it's the thing to do. So mandates, don't serve it's not that we're threatening to punish people if they don't. That's the lever that we have to change social norms to make sure everybody did that. And those, if I could sort of editorialize, for those of you, if you live in Dane County, you'll see it was a social norm. In fact, it's actually taking a hard time to wear off. Around coffee shops here in my neighborhood, probably half people are still wearing masks, even though it's not sort of mandated anymore. But these behaviors become normalized because they're a norm. Whereas in places where there were no mask mandates, other areas of the state, more rural areas and rural areas of the country, the most important predictor of whether one person is wearing masks is if other people in their area are wearing masks. So this was, I thought, helpful for our thinking. It certainly didn't make it any easier, maybe didn't make us more successful, but I think at least we know what kind of language to use when we're discussing policies that can influence behaviors. Okay, all right. And speaking of policies, this is the last the last experience I wanted to share with you, and this is one that Mary Muse knows well, of course, and this is some of the investigations we had to do or helped with in the Department of Corrections early on, and then some pretty challenging discussions that were had both at the state level and in smaller committees about how do you prioritize vaccines. And as I said at the beginning, I've been very interested in and cared very deeply about health as a human right, and that people who are incarcerated tend to sort of not always have their rights to the conditions that promote health respected in many countries. And it's really because we've taken away so many health promoting resources in terms of the ability to get outside and be free and have autonomy. I think we're obligated in an ethical sense to make sure that people who are incarcerated have excellent standards of health and health care. So how does that translate to the vaccine story? Well, I'm sure the first thing I'll say is this is probably also not a surprise to you, and these data are old now. This is from last fall when I first made this slide, but these have continued to climb because of probably the most important risk factor for COVID transmission is shared air, the lack of distancing, right? It's air breathed by one person who's infected that has particles that have been from someone else's airway. Places that are crowded, that don't have good ventilation and not an opportunity, are going to be the highest risk areas. And certainly jails and prisons were one of those. And the strategies that we use to try to make it to slow down aren't really possible. And so what that's translated to has been a large number of cases in prisons across the country. And this is a group of researchers that have studied COVID in prisons, and they used to have an ongoing dashboard. And I really can't say enough good things about how our Department of Corrections has been transparent with what they've been doing and encountering with COVID in their prisons. And it's been a challenge in every system, every correctional system, but we've worked together. We've worked closely. I answer a lot of questions from Mary and her colleagues, and my colleagues here in infection prevention have really worked as a team to do this. But as you see here, during that first wave in the fall, DOC had a lot of outbreaks and it went really quickly. And then over the next year, though, it really flattened out. And there's a lot of successes after that first wave that Wisconsin Department of Corrections can take a lot of credit for. And so this was another, and I'm mindful of time. I don't want to talk through the details of the sort of the outbreak so much, but this was another good example of working together to investigate kind of exactly how COVID-19 spreads in prisons. And this was an example again of kind of a blinking light or alarm sign that in one of our counties, in this case, I forget which county it was, but one of the facilities had a large outbreak, so large that the whole county numbers came up. And it was, again, we had a conversation with CDC, who has really sort of a backup role. And we said, well, what can we do to try to help turn the tide on transmission? And said, well, we can do an investigation. We can try to understand how it spreads. We can look at things like ventilation and spacing, and are the policies about isolation, quarantine different? And really from that, kind of a root cause analysis. And so we had CDC colleagues and laboratory colleagues work together to really characterize how this one Wisconsin prison went from having no COVID cases to a very large number of COVID cases, and found some specific strategies that could be changed or improved related to when people come into the prison. Typically, it's someone who's either transferred from a prison, from the community. They get incarcerated. They show up at the intake. The practice is to quarantine them for a period of time, but when many people are coming in, they can't necessarily quarantine them all individually. So someone completed their 14-day quarantine, but they turned positive, and they had already exposed someone else. And in this group quarantine, they had seeded the people in mother. So this was again, not a unique situation. This happened in probably almost every prison in the country. But we were able to, again, use use some resources to really understand it in detail and learn some lessons about how to tighten things up as best we can with some of these policies. And then this is more on the scientific side. We were able to get specimens that were done through the testing to the next generation sequencing and show that they were in fact all came from the same source. So rather than having 5 different people come in, the outbreak was all caused really by one source patient and then spread it to other people. So this was anxiety producing for many people, I'm sure, both in and out, the people whose families were in the prisons, the staff, the leadership who were trying to, maintain and the appearance that they're doing all the right things in this really impossible situation. But it was a good collaboration for learning some new things in a really challenging situation. So, and this was, in part, these kinds of experience led CDC to develop specific guidance on how to manage COVID-19 in correctional settings, how to do, if you run out of space, how to quarantine people in cohorts of people, if you don't have a single room for everybody, and how to minimize the risk of that. And then the last thing, that whole experience happened well before the vaccine era, but in the fall of 2020, we had the opportunity and also challenge to be able to plan for when vaccines were gonna show up. And a lot of that planning was for, initially, as I'm sure you all recall, who's going to get the first doses. There's initially going to be not nearly enough vaccine to go around. So states, by and large, were the level at which they need to make these policies about who's going to go first. The national, the CDC and the ACIP sort of gave a framework, but every state kind of had to make a determination of how are they going to classify people who got the vaccine first. Because at the end of the day, all the vaccine got purchased by the federal government. It got shipped to the states saying, here are your 500,000 doses. That's all you get. Figure out who gets it. And then states had to decide how they were going to distribute it to vaccinating clinics and pharmacies and offices and health departments. And then they had to come up with an orderly fashion of how they're going to decide who gets it first. And variations on this theme of how to come up with who should be in these early phase, who should go second, third, and then fourth. This was what was recommended by the CDC. What a lot of people who worked in correctional health were really looking for with this document is like where, there's some good cases to be made that people who are in prison should go toward the front of the line, regardless of their risk factors, because their risk is so high. And we heard later that this was a contentious issue, but as you can see here, what the national guidance is here was, there is no group here that say people who are living in correctional workers, but there was in the text, they said jurisdictions may choose to vaccinate people who reside in congregate living situations at the same time as staff because of their shared increased risk of disease. And so here you say, essential workers, like people who are working in congregate living situations. So it was not because this is a group of people that are medically underserved. It was because if they're essentially to keep the workers safe, we should also vaccinate the people who are incarcerated. So it was political, and in Wisconsin, it was very political as well. This was a counterpoint in the Wisconsin State Journal. This is actually my graduate student, Kristen, and a colleague in the Department of Medicine who wrote an op-ed about how delaying shots for prisoners by not putting them in the front of the line would be inhumane and unethical, because not only are we unable to use most of our prevention strategies in these prison settings, is that people who are incarcerated already have worse health statuses and come from stigmatized populations and and Black men are highly and disproportionately incarcerated in Wisconsin, and they have worse health outcomes. So really made the social justice argument for why people who have been traditionally neglected should get vaccines priority. And then, of course, the counterpoint was really one of fear mongering and convicted criminals shouldn't receive priority among our hardworking Wisconsinites, and accused the governor of prioritizing murderers, rapists, and child molesters. So, I mean, you could have predicted that those things would happen. But when we did it, and I was very proud of this. And I'll end with this. And again, as an opportunity to express my gratitude to Mary Muse, we had a committee called the State Disaster Medical Advisory Committee that was up to take up to this. And I invited Mary to be on this committee for a very specific reason. It was because I knew that when we got the medical experts together and we were wrestling with this, these different perspectives were going to come up. And I knew that if I said this, people should be, I think it would carry some weight. But when Mary Muse says it, and she says, "Look, I work with this population. The people who are in Milwaukee, Black men who have, I remember the conversation so vividly. It's like they have 10 years of aging and health consequences, just by living in the communities that they do and living the lives that they are." And she described so poignantly why this is really a moral imperative, that we protect people who have traditionally been unprotected. And I was very proud at the end of that whole process that this, unlike the national guidance, and unlike most states, when we said who's eligible in this first group, we said it's facility and the staff and the residents of congregate living settings, which essentially means homeless shelters and jails. So the policy allowed them to get started with vaccination in DOC earlier than they would have in many states were able to because of those policies. And at the end of the day, all this, we've done a better job in vaccinating our incarcerated population than pretty much any other group in the United States. That warms my heart to see. But there are some facilities, these data are from last fall as well, where they've had 97%. So that just blows the rest of the state out of the water in terms of how well people have accepted the vaccine and how well we've gotten it to them. So I give a lot of credit to our colleagues there. So that's taken us up to 8 o'clock, and I don't think you probably want me to talk much longer than that. So I'll stop sharing and get back to our gallery view here. And I would be happy to have any conversation if you'd like to ask questions or share any thoughts. Am I still sharing my screen? No.
Hi, Linda here. Thank you for a wonderful presentation. I have a question, and it's kind of about data, how much error there is in a lot of this data, because I know when I had my first bout of symptoms, I just bought a test kit at the pharmacy and I was positive, and I called my friend and I said, "Elaine, who should I tell about this?" I said, "It seems like I ought to report it to somebody." And so she said, "Put it on my chart." So I put it on my chart. I said, "Oh, I'm COVID positive." And then more recently, I had a second episode of COVID with international travel, and was tested negative 12 hours before the flight. 2 days upon return home, I was positive. Contact tracing, I have no idea who I got it from.
Yeah.
And so, I mean, any comments on that kind of data?
Yeah. Well, it's been a moving target. First of all, I'm sorry to hear that happened. I'm glad.
I'm all better though.
Hopefully you're feeling better. The most recent one, if it was in the past 3 months, it was the Omicron variant, and that is the story we heard over and over again. Is that people on the other side of the restaurant or the other side of the airplane, people getting infected with who knows when. We had, this was in the news, so I can share, but our first experience with the Omicron variant was a wedding of a returning traveler developed symptoms shortly after showing up, and in a like large reception hall, and 30% of the people tested positive, including people who were like wearing masks, serving food. So the whole being within 6 feet for 15 minutes was out the window. Everything had changed because the new variant was just so much more transmissible. And in addition, because the new variants were different, the antigen tests, which if you got a rapid test, were a little bit less accurate. We don't know exactly how less accurate compared to the PCR tests. They were about 80%. So it means, we'd miss 1 out of 5 cases. And that's happened a little bit more. So, but those are not unusual stories that particularly those tests, aren't perfect, but better than no testing. I think we're pretty clear that, knowing, to a large degree, but as time has gone on, it's been harder and harder to keep track of because of those, just the virus keeps getting smarter. Anything else? Yeah, Kathy. I still see your mute, Kathy with an IE. I still see you have your mute button on, so I can't hear what you're saying.
There. Okay, now.
There you go.
Early on, you mentioned the camp and how you tested and then isolated, and then suddenly they could go home. How to get them back? How did they get back? On a public bus? By car? By what?
Yeah, we had to adjudicate every single person, because if you tested positive or if you were exposed, you couldn't travel for 14 days, right? So we had to make sure that if someone was exposed, they were quarantined and stayed quarantined for 14 days. So we had to work backwards. We had to say, this is the time where everyone's going to leave. We had to do our testing to get everyone's status and then sort them in one building or the other. And hopefully, most of we'd stopped the transmission. The people who got it early. So essentially, we had to use their test results and a calendar, and some of them had to stay a day or two later. But if they got through those 14 days and tested negative, they could get on a plane or do what they ever needed to do. But that was public health in action. So we actually had power. Like, you can't get on a plane. Your parents can come pick you up if you want, but you're not going to fly to Florida until you're out of your isolations.
Okay, thanks.
Looks like Todd has a question.
I guess my question is about public health in general, rather than the specifics here. That there's been so much. I've been very troubled during the course of the COVID. That seemed like in the beginning of the COVID, there was some respect for public health and honoring it for the scientific message it gives us and how we respond because of that. But as time has gone on, that has withered on the vine in many areas. I'm wondering if you could just comment your perspective on public health and how it can regain some of that authority, shall we say, that it's lost. And it's really quite troubling that that's the case.
Yeah, that's been, I gave my thesis to you as one of the best things about the COVID response, or the things that felt good to me were some of the collaborative partnerships that working together. Clearly the worst thing, the hardest thing that I've experienced is really what you've described, and not experienced personally, but more at the level of local and tribal health departments. So the small communities around the state that have a health officer and a staff of a handful of nurses and administrators who are public health for 100,000 people in a large county, and they don't get. I think I don't think people disrespected them. They probably just didn't really pay them much attention beforehand, but they've been tirelessly working behind the scenes to get back, to do vaccinations, to report outbreaks and everything that they've been doing. And to see them be abused, frankly, for trying to do the right thing, for trying to promulgate the evidence-based recommendations about quarantine, has been really hard to see. And I've seen some of them that I've respected very much burn out and quit. And that's been heartbreaking to see. My perspective is not that we've necessarily, we at the particularly state and local levels, I don't feel like we've done things to disearn trust. And so nobody's perfect. We haven't done everything right. But I try to lead by example and give people who are express frustration with public health just a lot of grace, because it's been really hard. As a parent, I still love my kids when they're having a temper tantrum, and I kind of see it in that light. You know, we still love people in our community, but we've had a large scale temper tantrum by a lot of people who are sick of being told what to do. They're frustrated and demoralized, and they can take it out on people who have certain kind of positions and tell them things that it's really hard to hear. So how do we get out of that? It's going to be hard. I think there'll be some healing that happens just by time. My approach, and I really try to be a champion for public health workforce. I think people should go into public health. I think that nursing schools, I love it when I meet a nursing student who going through and says, I want to work in public. I mean, we need all kinds of nurses, obviously, but I get really excited when I see smart nursing students want to do public health. Obviously, some for everybody, we need nurses in ICUs and nurseries as well, but exposing people to the good and important work and is I think an important strategy. And so I get recharged by working with the next generation of people who work in health departments, try to build them up, and also just trying to try to do my part to keep morale up among health departments, because it's been so hard. We're a little bit insulated at the state, because it's a step removed, but in these school board meetings and the local health boards, it's really been ugly.
Thank you.
Like Catherine.
Oh, can I talk for a second? I just wanted to thank you for not only your presentation tonight, but all you've done for the state. I've seen you with the governor many times, with the Department of Health secretary, and the patience you guys have had, just as, talking about the people who don't want to follow, the recommendations by scientists is beyond me, and the patience that you guys have for that is amazing. But thank you for all you've done. Like I said, I've seen you plenty with the governor and helping, develop policies that have saved a lot of lives, even if they don't appreciate it at times. I mean, but there are plenty of people who do. So
yeah, I appreciate you saying that. Thank you. Louise, did you want to say something?
I have a question about the statistics. Before you started to really get things organized enough to know how to test people and how to tell people what to do, how many people probably, guesstimating, would have gotten COVID, maybe died at home or gotten sick at home and gotten better and didn't know they had COVID, that kind of thing? How much of that went on before everything got organized?
Well, we're pretty confident that we know who the very first person with COVID in Wisconsin was, because she knew she had COVID because she was traveling back from Wuhan, China on a plane and started having a fever on the airplane, and got off the plane, put on a mask, went to the hospital, said, I think I have this COVID because I just came from Wuhan, and got totally isolated And this happened on February 4th, 2020. So we had no testing in Wisconsin. So it was the hospital here in Madison. They've got a person in isolation, like we use for TB, and on the special ward. And she stayed in the hospital for a week under maximum precautions. And the test had to go to the CDC. It came back, it was confirmed. So she was like the 6th case in the United States. And then we didn't have, and she did fine. She did well. And then our second case that tested positive wasn't until March 5th. So there was a whole month there. And then we saw the kind of moving across the world. So when we started to see cases in March, it was going to be the tip of the iceberg. There were going to be people who didn't get tested, but there was so much attention to it. I think those first few weeks, those first couple of months, we probably captured most. I don't think it was, at least in Wisconsin, it wasn't circulating for a while before we knew it was here. I feel we're pretty confident we knew that the first case was here, but clearly there's been a lot of undiagnosed. Now these days, especially, the infection's spreads more quickly, also a little milder. So we've completely lost track of how many people, and we don't need to know right now. We know most people have gotten it, and most of us will if we haven't already. And we're in a much better place because vaccines have really saved a lot of people from getting severe disease. Sam.
Yeah, I'll just start with a comment and then a couple of questions. First of all, very proud to watch you tonight, because even though I don't know you, I feel I know you because you said you're from Walworth County, and I looked you up and you graduated from Delavan Darien.
I did.
We raised our kids in Elkhorn, and he had 2 sons who graduated in 93 and 94.
Yeah.
So you probably ran in a lot of the same circles. So
we probably did. Maybe ran track against him or something. Yeah.
Something like that. Yes, absolutely. Yeah. Anyway, so it's fun to see someone from Delavan,
Yeah.
And then the other, I guess my question is, a comment is, all the painstaking research that you did, and you had to learn things on the fly. You were learning things on the fly. Things weren't really black and white. And this is really just to echo Todd's question a little bit. How do you deal with all that politics when you are trying your best to understand some, the vagaries of this, that there aren't black and white answers.
Yeah.
And even as we go on now, as people are, quote, tired of this, for everybody in this video besides you, we are all at risk because we are older, and it's still a pandemic for us. And so anyway, a couple of questions in there.
Yeah. Politics have been, fascinating to watch, frustrating to see how, the negative impact of, I guess missed opportunities is a better way to phrase it. I mean, I agree with Catherine. We have done a lot of good. We've saved a lot of people's lives that's how it works, and they don't know that their lives have been saved, right? But we've lost 12,000 people. I mean, that's bigger than population of Delavan. 2 years died. So that's really the true north for me, is that there's I look at it, maybe it's my medical background, is I look at it like the difference between being able to save a sick patient and having them pass away is really the most important thing. And it doesn't, my wife sees this every day. She's an emergency medicine physician, and you're with a sick patient who's dying. It doesn't matter if someone's yelling at you or hates you. You're just going to do the right thing for the patient, and then go home and get your love at home, as she says. So it's a little bit of that. It's a little bit of you know, we're here to love people, whether they love us back or are grateful for it or not. The other thing that's been, I think, a coping mechanism for me is just to feel part of a team. And I have a good mentor here. One of the other chief medical officers, John Myman, has been here for 10 years, longer than me. You know, really kind of put that into stark terms. He goes, I'm not a political actor at all. I'm just like the medical advisor. And in a lot of the policies at the beginning, when things were so contentious, you know, when Andrea Palm was the DHS secretary and it was a lot of controversial, and all the things around the Supreme Court. Yeah, John, you know, told me there's kind of two kinds of people that work around here. There's policy people and there's civil servants, and we're civil servants, and no one appointed us. We can't fire us. We're here because we want to help, and we're good at it, and we know what we're doing. So feeling comfortable in that role, almost like you're the physician. It doesn't make it mean it's not hard, but it helps you feel like, you know, you're working in a challenging situation, but you can keep your eyes on the prize and try to tell the truth and be honest with people, and you know, just do your best work. So that's how I'm pretty thick-skinned that way. In my clinical practice, I've taken care of people who are not always nice to me, and you got to learn how to do that, how to do your job. So it's like, you know, it's like prison medicine on a population scale, you know. But that actually, you know, I love my patients who are in prison. Like they're by and large very, very pleasant to work with. I enjoy working with them. But you know, sometimes you get some unpleasant situations, but you keep at it.
Great, thanks. Thank you.
So Ryan, I appreciate you talking about the incarcerated population a bit. Often I would get asked, oh my God, what is it like to care for people in prison? Or you would hear those who work in prison get frustrated sometimes when our population wants to get health care. They're like, I'm not sure if they really need the health care. They just wanted to come up to the health service. But could you imagine being in a room that's probably the size of a closet and that's all you got? So one of the things for me, I think Covet is a better example of trying to explain to people what it's like for someone incarcerated, where you're restricted. It's like if we who are free could not stand the fact that we had to wear a mask and we had to have some distance between us and someone else, or we couldn't go out to a restaurant to eat. We couldn't take that. But there are people, you know, who are incarcerated, millions, who that's what they have to live with every day.
Yep.
Without choices. So
that's a good point.
It's a good descriptive of that. And even with there were people who recognized the work of health staff, public health, and in the hospitals. But I often thought the one group that did not get or doesn't get that acknowledgement are the folks who work in correctional health care. Because just like our population, we're just kind of hidden behind bars. And so with the exception of those, and there were prisons who had lots of deaths or bad outcomes through COVID. Thank God we weren't one of them, but you know, there were that had them. But you know, can you imagine? We saw the nurses from the hospitals. Can you imagine what it was like to be in a correctional setting where you don't even have all the resources that you need, and you're trying to keep someone safe?
Yep.
But thank you for being a supporter. And I have to say, the one thing I thought from my role is that the state lab, people like Ryan, Dr. Westergaard, they cared about us and our population. And so they were willing to work to help us to get the resources we need, to get the tests done we needed, to have the conversations whenever we wanted to have a conversation. And I think that was so important too, in terms of that, just working together.
Well, maybe we'll leave it there. Thanks for thanks for your
You
time,
here.
and thanks for inviting me to be with you. It's great to
Thank
chat
you
with
so much. It was
Thank
a
you very,
wonderful,
very
wonderful presentation.
Thank you, thank you, thank you.
Okay. All right, guys, I'll have a good night.
Until our next epidemic, right?
Oh, gosh.
Please no.
Okay. All right. Bye-bye.
I'm sorry, I made that joke, but take care. Thank you, everyone.
you so
Thanks,
much.
Mary, so much.
Thanks, Linda.
Thanks a lot.
Thank
So
you.
long.